a perfusion issue or an inflammation issue? Who is for the perfusion?
Can be both.
Or both? Or both? Perfusion, inflammation, both?
Both.
Maybe some people have voted more than once. You know, you are Corsican, as I am, you know, you can vote all the time until you get your candidate elected. So this is a case I would like to show you, and just to try to separate the perfusion issue or the inflammation issue to explain the organ failure. This is a lady around 80 years old. We are not as rich as the institution of Michael, so we have old people, French people, you know, no money and nothing else, okay? So she got a thrombocytopenic purpura, and she was treated as an autoimmune disease with a splenectomy and something which is the romiplastin, which is a growth factor for stimulating the bone marrow to synthesize platelets, okay? Mm-hmm. Then, after a couple of months, she was treated successfully for this first disease, autoimmune disease, and she became sick, and she lost weight, 20 kilos in 4 months, and she was going to be explored. And then you see that she got a tumor on the esophagus. And the surgeon said, what should we do? And as usual, we propose, or they propose, some chemotherapy, FOLFOX6. You know this protocol, which is an anti-cancer drug, which doesn't work at all, but we continue to give. And nobody is criticizing this because cancer needs to do something. In the ICU, if you do something for the sepsis, you are stupid because it doesn't work. So you have to stop. In the cancer, you never stop. That's a big difference between the two. And then she got a surgery, which was a Lewis Santi. I don't have the time to go through. And then she went to after the esophagectomy, she went to the ICU. The day one, she was not so well. I mean, hypoxemic, and she got a chest drainage. She got a cardiovascular collapse. And then we give, as usual, fluid challenge, as you do probably. I don't know about what kind of fluid. I don't care for the moment. And she got an acute kidney injury, which was classified AKIN 3. And she was maintained like this, so-so, not so well, not so bad. And the surgeon said, I did a perfect surgery. You know this. Surgeon is always doing a perfect surgery. The patient is not tolerating well the perfect surgery sometimes. And that's the issue. And day 8, you get a severe source, and she got an increase in the white cells, moving from 6,000 to 64,000 white cells. Mm-hmm. What means the increase in white cells? Is it because you stimulate too much the bone marrow? Is it because you are not using at all the white cells for the different places the cells have to go? A combination of the two?
Paradoxical effect of chemotherapy.
A logical effect of chemotherapy, which is pushing the cells to get out. Not so frequent, you know. What do you think? Why the lady is getting 64,000? Tell me. Maurizio, yeah. He is British and Italian, so he got the two aspects for the life, which is great, you know. I love that. No, I mean, she moved to 64. What does it mean for you? You say inflammation. If you get a higher number of cells in the blood, which means that the cells are not going to the tissue, it means more inflammation? Maybe. She had no fistulae. She got a bronchoalveolar lavage with a little bit of bacteria, but we cannot say anything else for that. No leak, no mediastinitis at this time. We were looking at the lady like this as the stupid doctors, and we say, maybe tomorrow we'll get another information. Day 11, multiple organ failure. Look at the white cells. 223,000 white cells. You have seen that before? Who has seen, except the leukemia, which is not, this is not a leukemia, she got a normal white cells, 223,000 white cells. Did you see that before? You are very young. I'm very old. I never saw that too. So probably this is the world record for, because remember, she got a romiplastin, which is a growth factor that I don't know very well, to be honest, and the guy who is giving the drug doesn't know well too. But doesn't matter, it's for, you know, it's for hematology. Hematology, you get the right to do whatever you want. And I said, listen, this is a growth factor. Maybe it's stimulating a lot the white cells to get out the bone marrow, and the bone marrow is stimulated to release a lot of cells, including the white cells. He said, maybe. I said, I'm sure. And then we'll look at these cells, and then with this number of cells, if these cells are very aggressive, you suspect that these cells will go to the tissues and kill something there, bacteria, for example, but also the tissues. And then you can get some organ failure, right? At least it's reasonable to think about it. And then the organ failure could be the cardiovascular, could be the lung, could be the kidney, could be all the organ failure you know. Okay, no fistulae. She got some kind of so-called commensal bacteria, which is becoming perhaps pathogenic, Citrobacter. Despite of 223,000 white cells, bacteria are still there. Come on, what the police does. You see here norepinephrine shock, 1.6 milligram per hour. Cardiovascular failure, right? At the same time, she got a kidney failure, which was almost stable, 130 creatinine. Minimal of creatinine. You see the PMNs moving to 100 and moving to 200,000. And you see the SOFA score, which was almost normal initially, move to around 10. And then the PF ratio started to decrease. So she was not well, and the trend was not great. What do you propose to do? Okay, thank you very much. It helps a lot. Okay. At this time, she moved to 223,000 white cells. You see the PF ratio. You see the white cells here, essentially polymorphonuclear cells. Here you see the SOFA score, around 15. You see the creatinine is going to rise. At this time, I decided, why not, to give Hydrea. You know the Hydrea? Hydroxy? Okay. Which is a poison for DNA replication. We say that it works well. You say that to the doctors and they accept. And then we give one shot. Boom. And you see after the one shot, the absorption is around 1 to 3 hours. And then it's efficient immediately. And you see the day after the decrease in the white cells number, and then decrease again to 30,000 white cells. At the same time, you see the PF ratio went up, the creatinine stopped to rise and started to decline, the SOFA score decreased, and we stopped the norepinephrine. Are you convinced that this is the white cells which is doing the organ failure, which means inflammation, more than the shock itself? Who is convinced? Only one? Two? The others are not convinced? You are not convinced by that? You decrease the white cells and you improve the organ failure? It's coming from where? Tell me. Viscosity was normal. We measured this. 10% over the normal value because the red cells were down. So the red down, the white up, normal viscosity. Any other comment? Yes, please. Of course, my friend. We measure the white cells activity. Ha ha. And I will show you. Any other?
Why do you think the viscosity was not a problem? Don't you expect that the pH ratio improved when actually you depleted the white cells from the lungs as well?
No, I don't think so, because at this time we got 120, and this time we get 65, and then you see the pH ratio 1:330. Could be a part of this, but the modest effect. Modest effect. You disagree. Okay, they don't trust me. Ah, that's amazing. You know, we got the proof in front of you, and they continue to say no. Come on. Controlling immunoinflammation, improve organ failure. The cardiovascular failure was stopping rapidly. Do you think it's due to the white cells reduction, you know, by viscosity and so on? You have paper on that?
No.
Never published. Never exist. The lung increased the pH ratio because of what? You know, the hypoxia is not a ventilation issue, it's a perfusion issue. So you think that you improve the perfusion of the lung with the reduction in white cells? That's the point, not the lesion of the lung, maybe. And the acute kidney injury, how do you deal with? It's stabilization and improvement related to the viscosity, which was normal, by the way. Okay, go to the microcirculation and see what happens. Okay, NIRS, you want the NIRS? Near-infrared spectroscopy to see if it's abnormal, the tissue oxygenation. Let's go. We are measuring this, the STO2, the slope of occlusion, the slope of reperfusion, which is always the parameter which is telling you something is abnormal or not. Here you see STO2. Then you give the dose of Hydrea, you see the STO2 goes up. You see the reperfusion slope, which was abnormal and extremely slow, became better, rapidly improved in 2 days. And that means that we were able to improve at least the tissue oxygenation, in this case with the reduction of the white cells. Okay? Are you convinced about that? She is always doubtful. I mean, she doesn't trust. She see, but she said no. You see Obama, no, it's not Obama. It's the day is the day. It's not the night, no, but it could be the night. Okay. We take another one, which is a perfusion one, the laser Doppler. You know the laser Doppler. You put on the skin at the same place as the NIRS. Okay. Norepinephrine 1.6080. Laser Doppler 1.3, 2.5, 1.8. So nothing very special for the flow in the skin. So the viscosity is disappointing you, my friend. Come on. The blood pressure was, because 108, 77, 47, we have to put a bit more, and then you go back to 71, and you get relatively stable laser Doppler in the skin, which means that this flow is not mainly determined by the blood pressure, by other issues. Okay, you go to the sublingual area, the Janine story, and then you expect something, you see, okay, if it works. You see the white cells on the vein, and you have some vessels which are not perfused, but still, most of them are perfusing well. Do you agree with? Except that you see a lot of white cells, but it flows, right? So the viscosity maybe is not the issue. It flows, right? Okay. You go to the immune inflammatory monitoring, okay? What do you want to know? Adhesion molecules. If the white cells are very toxic, they have to get the expression of adhesion molecules to stuck to the endothelial cells and to go through, right? Or maybe the reactive oxygen species release. If they are very productive, that might be dangerous. If they are not, it's less dangerous for the tissues. No? We don't care? You don't like the RAS? You don't want to know the RAS activity? It's the key issue for the organ failure. It's a key issue. The more you release the ROS, the more you kill the bacteria, the more you kill the tissue. Uh-huh. You disagree? Or you are still on the viscosity? You move to the ROS? Thank you. The ROS is important or not? Hey, guys! Blood pressure, forget the blood pressure. Who cares about the blood pressure? That's the problem now. What happens at the tissue level? At the microcirculation, there is no blood pressure. There is over 20. Who cares? The question is, are the white cells doing the damage on the tissues, right? You are not reacting too much because, you know, I see the guys say echo. It's not the echo issue there. It's the molecular patterns which is killing the normal cells. Come on. Hydrea is ROS production for the PMNs. Boom! Aha! Very normal values. You know, the activity of the white cells, 223,000 white cells very active for ROS production. They kill all the tissues. Do you agree with or not? I show you the ROS production, and she is still doubtful. Come on! How can you be like this? Incrédule, we say in French. Incrédule. They don't trust. Then you see, here you see the adhesion molecule, CD11B, you know? And you have here the CD11B in blue on the monocytes, and on the green is on the white cells, except this is the inverse, sorry for that. This is the monocyte in blue, the PMNs in blue and the monocytes in green. You see something which is very bizarre for me, I don't understand well. For the PMNs, it's almost stable. The expression of the adhesion molecule was normal, not elevated, but was absolutely stable even when you give Hydrea. And for the monocytes, reducing the number of PMNs, the monocytes got a better response for adhesion molecules. And that's something which is a link between the... Yes?
One question. The option of the leukophoresis.
We discussed about the leukophoresis, so how to eliminate this. But it's a long time, it's very dangerous, and it's quite unstable patients to do. And the guy for hematology refuses to come to do it in the ICU. And it was very, very, very nice to do this with a drug, finally. And then she recovered well, and she left the ICU with normal number of white cells. She was recovering the kidney function until 110 millimoles of creatinine, which is, for this lady, not normal, but acceptable. She was never supported mechanically, at least. And she is a nice lady now, and she is still limited because after 1 month of the ICU, but she is alive. So the classic view is to say shock is cardiovascular failure, which is leading to the organ failure, which is not true at all. Which is not true at all. I have tons of arguments against that. Cardiovascular failure, the shock is one failure, for sure. Then if you keep this for a long time, you can create ischemia and organ failure. It's true. But usually at the acute phase, in the first 24 hours, you get a cardiovascular failure with the other failures. All of them are organ failures, no more, because of the inflammation. For simultaneous organ failure, so you get a shock, you get a kidney failure, you get a lung failure, same time. Come on, it needs time to do the ischemia and then to get organ failing if it's only the perfusion. Pleocytosis, I never found any literature for that showing the number of white cells over 100,000, so it's new and there is no publication on that. Reducing the number of neutrophils was rapidly possible with the drug that the cancer people are using. The organ failure improved rapidly until you stop this pleocytosis, and the inflammation predominates on perfusion for the organ failure. I hope I convince you about that, except you, lady. I will never be successful with you, I know that. Do you agree with this? Do you remember patients for whom this perfusion itself was not really explaining well the things. And you get 2 organ failures, and sometimes without shock, and they continue to die. Sometimes you get a shock plus 1 other organ failure, and they can be resuscitated. Remember the papers on the steroids showing that the pressure went up, and you die more. You prefer to die with a good pressure or to survive with a lower pressure? What do you prefer? She preferred to die with a good pressure. Okay.
In ICU medicine, we are much more afraid of leukopenia and sepsis and of leukocytosis. Can you discuss that?
Yeah. That's something which is ongoing to be investigated for now. So the number of white cells. Usually you get this very easily every day. You get the number of white cells, and nobody takes care. If you ask to the residents, give me the number of white cells, sometimes they give you the global number. If you ask for the number of lymphocytes, they have no idea. Usually the doctors are very well aware for the HIV people. Below 400 or T4, it's as AIDS, and they are very anxious about it. Do you know how many patients with septic shock have a CD4 number below 400? 85%. Who cares about that? Nobody. T cells are key cells. Who cares? Nobody. They prefer to look at the blood pressure and the lactate. Does not make sense. Why do you look at something which is interesting to know, to guide you, and not to the cells which is doing the job of killing the tissues? That's something I don't understand. And we have the information. It's cheap. It's not expensive. We can get it every day, twice a day, whatever. And the ratio between the PMNs and the lymphocytes is probably key. It's under investigation in many centers now. So we'll get the results in 2015.